Sexual disorders, case study for sexual disorders from Kaplan and Sadok, page 702 to 703. George was a 22-year-old single man referred following his fourth arrest. He would usually expose himself from his car to women in their late 20s. The victim's response was to laugh, to be startled and run away, or to make harsh comments to him. Following his first exposure, he concluded there was nothing to it, and he did not expose himself again until 4 months later. Since then, he exposed himself 2 or 3 times per month. Exposures occurred in waves, followed by a period of up to a year of no such activity. His fourth arrest had led to minimal consequences for him. During the year prior to referral, he had a rich sexually enjoyable relationship with his girlfriend, with frequent intercourse and without sexual dysfunction. An intelligent student, George logically appreciated the inappropriateness of his exposing himself. Although he hoped for a sexual encounter with one of his victims, it never occurred. Although 15% of his masturbatory fantasies involved recalling previous episodes of exposing, the remaining fantasies were of normal heterosexual intercourse. An increased intensity of his urges to expose were provoked by seeing his female peers walking or driving by themselves. He would follow a woman in his car while fantasizing her possible positive reaction should he expose himself. These fantasies were soon accompanied by masturbation while driving. His excitement and anxiety intensified as the time of his attempted exposure approached. Exposure was usually to a woman in her car while driving his car, a technically difficult feat fraught with danger. Typical was his careless disregard for protecting his identity. George made minimal attempts to conceal his appearance, the characteristics of his car, or even his license plate. After a series of exposures, he would be overcome by depression and intense guilt. He would resolve not to expose himself again, but after 1 to 6 weeks, his cycle of recurrent urges and exposures would return. Sexual norms. Sexuality is profoundly shaped by culture and experience, so it is important to be aware of subjective biases in thinking about diagnosis. Gender also shapes sexuality. For example, men report more frequent sexual thoughts and behaviors than do women. Kaplan described 4 phases of the sexual response cycle: desire, excitement, orgasm, and resolution. Over time, researchers have learned that the Kaplan phases do not fit the data for women in 2 ways. The desire and excitement phase may not be distinct, and the Kaplan definition of the excitement phase may be overly biological. Sexual dysfunctions. In the DSM-5, the sexual dysfunction disorders are divided as follows: sexual interest, desire, and arousal disorders, female sexual interest, arousal disorder, male hypoactive sexual desire disorder, and erectile disorder. Orgasmic disorders, female orgasmic disorder, delayed ejaculation, and premature ejaculation. Sexual pain disorder, genitopelvic pain, and penetration disorder. Delayed ejaculation, a disorder in men involving delay in reaching orgasm or inability to reach orgasm. Desire phase, the first stage of the sexual response cycle characterized by sexual interest or desire often associated with sexually arousing fantasies. Dyspareunia, DSM-4-TR diagnosis for persistent or recurrent pain during sexual intercourse, not attributable to a medical problem. Erectile disorder, a recurrent and persistent inability to attain an erection or maintain it until completion of sexual activity. Excitement phase, as applied by Masters and Johnson, the second stage of the sexual response cycle characterized by pleasure associated with increased blood flow to the genitalia. Female orgasmic disorder, a recurrent and persistent delay or absence of orgasm in a woman during sexual activity adequate in focus, intensity, and duration. In many instances, the woman may experience considerable sexual excitement. Female sexual arousal disorder, formerly called frigidity, the inability of a female to reach or maintain the lubrication, swelling stage of sexual excitement, or to enjoy a subjective sense of pleasure or excitement during sexual activity. Female sexual interest arousal disorder, a sexual dysfunction characterized by a loss of sexual interest, urges, fantasies, or desires, or lack of physiological or subjective arousal to sexual cues. Genitopelvic pain penetration disorder, a disorder in which the woman persistently experiences pain or vaginal muscle spasms when intercourse is attempted. Male hypoactive sexual desire disorder, a sexual dysfunction disorder defined by absence of or deficiency in sexual fantasies and urges in men. For women, see sexual interest or arousal disorder. Male orgasmic disorder, a recurrent and persistent delay or absence of ejaculation after an adequate pace of sexual excitement. Orgasm pace, the third stage of the sexual response cycle, characterized by a peak of sexual pleasure, generally including ejaculation in men and contraction of the outer vaginal walls in women, premature early ejaculation, and ability of the male to inhibit his orgasm long enough for mutually satisfying sexual relations. Resolution phase, the fourth and final stage of the sexual response cycle, characterized by an abatement of muscle tension, relaxation, and a sense of well-being. Sexual dysfunctions, dysfunctions in which the appetitive or psychophysiological changes of the normal sexual response cycle are inhibited. Sexual response cycle, the general pattern of sexual physical processes and feelings, made up of four phases: appetitive interest, excitement, orgasm, and resolution. Vaginismus, DSM-IV-TR. Diagnosis defined by painful spasmodic contractions of the outer third of the vagina, making penetration impossible or extremely difficult. Although there are no good estimates of how many people meet full diagnostic criteria for sexual dysfunction disorders, in one major survey, 43% of women and 31% of men reported at least some symptoms of sexual dysfunction. People who experience one sexual dysfunction disorder often experience a comorbid sexual dysfunction disorder. For example, a man who is experiencing premature ejaculation may develop hypoactive sexual desire disorder. Before diagnosing sexual dysfunction, it is important to rule out medical explanations for a symptom. The key etiological variables involved in sexual dysfunctions appear to be previous sexual abuse, relationship problems, lack of sexual knowledge, psychological disorders like depression, anxiety, or alcohol abuse, low arousal and exhaustion, and negative cognitions and attitudes about sexuality. For premature ejaculation, one possible cause is an overly sensitive penis. Penile plethysmograph, a device for detecting blood flow and thus for recording changes in the size of the penis. Spectator role, as applied by Masters and Johnson, a pattern of behavior in which the individual's focus on and concern with sexual performance causes him or her to be an observer rather than a participant, and thus impedes natural sexual responses. Vaginal plethysmograph, a device for measuring physiological signs of sexual arousal in women. The device is shaped like a tampon and inserted into the vagina to measure increases in blood flow. Psychological treatments for sexual dysfunction include techniques to reduce anxiety, to increase knowledge and awareness of the body, to reduce negative thoughts about sexuality, to improve couples communication, and to reduce performance anxiety. Medical treatments are increasingly popular. Despite some criticism, medications such as Viagra and Cialis are commonly used to treat erectile dysfunction. Antidepressant drugs and the squeeze technique can be helpful in the treatment of premature ejaculation. Sensation focus, a term applied to exercises prescribed at the beginning of the Masters and Johnson sex therapy program, in which partners are instructed to fondle each other to give pleasure but to refrain from intercourse, thus reducing anxiety about sexual performance. Paraphilic disorders. Paraphilic disorders are defined by a sexual attraction to an unusual sexual object or activity that lasts at least 6 months and causes significant distress or impairment. The DSM diagnostic criteria for paraphilic disorders are distinguished based on the object of sexual attraction. The major DSM-5 diagnoses of paraphilias include fetishistic disorder, pedophilic disorder, voyeuristic disorder, exhibitionistic disorder, frotteuristic disorder, sexual sadism disorder, sexual masochism disorder, and transvestic disorder. Exhibitionistic disorder, exhibitionism, marked preference for obtaining sexual gratification by exposing one's genitalia to an unwilling observer. Fetishistic disorder, a paraphilic disorder that involves reliance on an inanimate object for sexual arousal. Frotteuristic disorder, a disorder in which the chief concern involves the sexually oriented touching of an unsuspecting person, typically in public places that provide an easy means of escape. Paraphilic disorder, sexual attraction to unusual objects or unusual sexual activities that leads to social difficulties or distress. Pedophilia, a paraphilia defined by a marked preference for obtaining sexual gratification through contact with people defined legally as underage. Sexual masochism disorder, a paraphilic disorder defined by a marked preference for obtaining or increasing sexual gratification through subjection to pain, or sexual sadism disorder, a paraphilic disorder defined by a marked preference for obtaining or increasing sexual gratification by inflicting pain or humiliation on another person. Transvestic fetishism, the practice of dressing in the clothing of the opposite sex for the purpose of sexual arousal. Voyeuristic disorder, a disorder defined by a marked preference for obtaining sexual gratification by watching others in a state of undress or having sexual relations. Researchers do not know the prevalence of these disorders, nor is much research available on the causes of paraphilic disorders. Neurobiological theory has focused on excessively high levels of male hormones, testosterone, but the theory has not received strong support. Psychological theories focus on conditioning to inappropriate sexual objects, histories of physical and sexual abuse, poor parenting, social skill deficits, hostility toward women, and cognitive distortions. Alcohol use and negative affect are often immediate triggers of inappropriate sexual behaviors. Incest, sexual relations between close relatives, most often between daughter and father or between brother and sister. The research evidence regarding treatments for paraphilic disorders is limited. Treatment approaches must begin with a focus on engaging and motivating the client, which is often difficult to do. Early cognitive behavioral approaches focuses on aversion therapy, including covert sensitization, and cognitive techniques to challenge distorted beliefs about the consequences of sexual behaviors. Over time, cognitive behavioral therapists have also begun to use techniques to improve social skills, to help people control impulses, to increase empathy for potential victims, and to identify potential high-risk situations for the return of symptoms. The most common medication treatments involve antidepressants or medications that reduce male hormone levels, but the research on antidepressants is poor and the hormonal medications have serious side effects. Laws have been passed that allow the public to access information about where sexual offenders live, but civil liberties groups are opposed to some aspects of this law. Additional notes on sexual disorders. Sexual disorders, biological causes of sexual dysfunctions. One of the most common contributors to sexual dysfunction is diabetes, which can lower sexual drive, arousal, enjoyment, and satisfaction, especially in men. Diabetes often goes undiagnosed, leading people to believe that psychological factors are causing their sexual dysfunction, when their cause actually is undiagnosed diabetes. Other diseases that are common causes of sexual dysfunction, especially in men, are cardiovascular disease, spinal cord injury, and injury to the autonomic nervous system due to surgery or radiation. As many as 40% of cases of erectile disorder are caused by one of these medical conditions. In men, abnormally low levels of testosterone and other androgens or high levels of estrogen, in other words, estradiol, and prolactin can cause sexual dysfunction. In women, levels of both androgens and estrogens may play a role in sexual dysfunction, although less consistently so than in men. Estrogen problems in women may result in low arousal cost due to reduced vaginal lubrication. Levels of estrogen drop significantly at menopause. Thus, most postmenopausal women often complain of lowered sexual disorder and arousal. Similarly, women who have had a radical hysterectomy, which removes the ovaries, the main source of estrogen, can experience reductions in both desire and arousal. Androgens also play a role in the maintenance of sexual desire and also may enhance the function of vaginal tissue. Vaginal dryness or irritation, which causes pain during sex and therefore lowers sexual desire and arousal, can be caused by antihistamines, such as tampons, vaginal contraceptives, radiation therapy, endometriosis, and infections such as vaginitis or pelvic inflammatory disease. Injuries in childbirth that have healed poorly, such as a poorly repaired episiotomy, can cause sexual pain in women. Women who have had gynecological cancers sometimes report pain, changes in the vaginal anatomy, and problems with their body image or sexual self-concept. Several prescription drugs can diminish sexual drive and arousal and interfere with orgasm. These include antihypertensive drugs for high blood pressure, antipsychotic drugs, antidepressants, lithium, and tranquilizers. Many recreational drugs, including marijuana, which can cause vaginal dryness, cocaine, amphetamines, and nicotine, can impair sexual functioning. Although people often drink alcohol to make them feel sexier and less inhibited, even small amounts of alcohol can significantly impair sexual functioning. Chronic alcohol abusers and alcohol dependents often have diagnosable sexual dysfunctions. When a sexual dysfunction is caused by substance abuse, it is given the diagnosis substance-induced sexual dysfunction. To determine whether a man is capable of attaining an erection, clinicians do a psychophysiological assessment with devices that directly measure men's erections. In a lab, strain gauges record the magnitude, duration, and pattern of arousal, which he watches erotic films or listen to erotic audio recordings. For women, the physical ability to become aroused can be measured by a photoplethysmograph, a tampon-shaped device inserted into the woman's vagina that records the changes accompanying vasocongestion, the rush of blood to the vagina during arousal, psychological causes of sexual dysfunctions, mental disorders, aside from the sexual dysfunction, such as anxiety disorders, GAD, panic disorder, OCD, depression, and antidepressants, attitudes and cognitions, being thought that sex is dirty, disgusting, or sinful, or a necessary evil, knowing little about one's own body and sexual responses that one doesn't know how to make sex pleasurable. Women, both older and younger, report a fear of letting go, in other words, loss of control, which interferes with orgasm. Fear of loss of control may result from a distrust of a partner, a sense of shame about sex, a poor body image, and a host of other factors. Performance anxiety. When people worry about being aroused or having an orgasm, that their worry interferes with sexual functioning and inability to focus on the pleasure of sexual stimulation. Spectatoring. When clients anxiously attend to reactions and performing during sex as if they were spectators and not participants. Interpersonal factors, conflicts regarding couples' sexual activities, relationship problems, inability to achieve an orgasm in women may be tied up to a lack of communication between them and their partners regarding what the women need in order to achieve an orgasm. Treatments, early or premature ejaculation. Antidepressants like SSRIs can reduce frequency of early premature ejaculation. Individual psychotherapy, mechanical intervention for erectile disorder in men, such as prosthetic devices surgically implanted into the penis, hormone therapy for both females and males for sexual desire disorders, paraphilias, behavioral theories of paraphilias due to an initial classical pairing of intense early sexual arousal with a particular stimulus. Give an example: child becoming aroused when spying on a maid's lovemaking with her boyfriend. This might be followed by intensive operant conditioning in which the stimulus is present during masturbation. Give an example: the individual may repeatedly fantasize about a particular scenario, such as watching the maid have sex while he is masturbating. This reinforces the association between the stimulus and sexual arousal. The individual may try to suppress the undesired arousal or behaviors, but those attempts at inhibition increase the frequency and intensity of the fantasies, and eventually the sexual arousal may generalize to other stimuli similar to the initial fantasy, such as actually watching other people have sex, leading to paraphilic behavior, in other words, voyeurism. Often a person with paraphilia has few opportunities for other types of sexual reinforcement and has difficulty relating appropriately to other adults. The classical behavior theories have been supplemented with principles of social learning theory. We suggest that the larger environment of a child's home and culture influences his or her tendency to develop sexual deviant behavior. Children whose parents frequently use corporal punishment and engage in aggressive contact with each other are likely to engage in impulsive, aggressive, and perhaps sexualized acts toward others as they grow older. Many people with paraphilias have poor interpersonal skills and feel intimidated when interacting with sexually with adults. Childhood sexual abuse was a particularly strong predictor of pedophilia. Studies of juvenile sex offenders, most of whom assaulted a younger child, find that many likely suffered sexual abuse. Cognitive theories have also identified a number of distortions and assumptions that people with a paraphilia have about their behaviors and the behaviors of their victims. These distortions, assumptions, and justifications, such as misattributing blame, in other words, blaming the victim, minimizing or denying sexual intent, debasing the victim, minimizing consequences, deflecting censure, I only did it once long ago, and justifying the cause, may have learned from parents deviant messages about sexual behavior. They are used to justify the person's victimization of others. Biological theories of paraphilias. Several lines of evidence suggest that alterations in the development of the brain hormonal systems may contribute to pedophilia. Men with pedophilia are more likely to have had a brain injury before age 18, to have cognitive and memory deficits, to have lower intelligence, and to have different in brain volume. Men with pedophilia seem to have dysfunctions in the frontal area of the brain involved in regulating impulsive and aggressive behavior and in testosterone levels. Treatments for the paraphilias. Treatment is often forced on those who are arrested after engaging in illegal acts including voyeurism, exhibitionism, frotteurism, or pedophilia. Simple incarceration does little to change these behaviors, and convicted sex offenders are likely to become repeat offenders. Biological interventions are generally aimed at reducing the sex drive in order to reduce paraphilic behavior. Surgical castration, which almost completely eliminates the production of androgens, lowers repeat offense rates among sex offenders. Castrations have been performed on hundreds of convicted sex offenders in the Netherlands, Germany, and the US, although it is rarely used today. Side effect: gynecomastia. The breasts become enlarged. Sex offenders can be offender anti-androgen drugs that suppress the production of testosterone and thereby reduce the sex drive. These drugs are typically used in conjunction with psychotherapy and can be useful for hypersexual men who are motivated to change their behavior. People treated with anti-androgen drugs show reductions in their paraphilic behaviors, although the results are mixed. The SSRIs have been used to reduce sexual drive and paraphilic behavior. Behavioral modification techniques are commonly used to treat paraphilias and can be successful if people with paraphilia are willing to change their behavior. Aversion therapy, used to extinguish sexual responses to objects or situations a person with pedophilia finds arousing. It may involve, for example, exposure to painful but harmless electric shocks or loud bursts of noise while viewing photos. What arouses them? children. Give an example. Desensitization procedures may be used to reduce a person's anxiety about engaging in normal sexual encounters with other adults. Give an example. People with aphorophilia might be taught relaxation exercises, which they then use to control their anxiety, or they gradually build up fantasies or interacting sexually with other adults in ways that are fulfilling to them and their partners. Such behavioral treatments are generally effective in the treatment of non-predatory paraphilias as fetishism. Cognitive interventions may be combined with behavioral interventions designed to help people learn more socially acceptable ways to approach and interact with people they find attractive. Role playing might be used to give the person with a pedophilia practice in approaching another person and eventually negotiating a positive sexual encounter with him or her. Also, group therapy, in which people with paraphilia support one another through changes in their behavior, can be helpful. Multiple studies find that these combined cognitive behavioral treatments can effectively treat non-predatory paraphilias in individuals motivated to change. Cognitive behavioral therapy has also been used to help people with a predatory paraphilia. Give an example: pedophilia, voyeurism, exhibitionism. Identify and challenge thoughts and situations that trigger their behaviors and serve as justifications for their behaviors, but with limited success. Sample test questions on behavioral disorders. Next. A 25-year-old man is brought to the emergency room by the police. He has been rubbing his penis against unsuspecting young women in the subway. He was apprehended by the police and became suicidal, saying that his arrest would ruin his job and ruin his relationship with his family. What is the most likely diagnosis? A. Frotteurism. B. Major depression. C. Paraphilia not otherwise specified. D. Pedophilia. E. Voyeurism. Which of the following is true concerning erectile disorder? A. Diabetes is the leading cause of erectile disorder in the United States. B. It is inevitable in old age. C. It is not caused by Parkinson's disease. D. Erection is dependent on the sympathetic nervous system. Female orgasmic disorder is A. More common after 35 years of age. B. An uncommon sexual disorder of women. C. Also known as inhibited female orgasm or anorgasmia. D. Never caused by psychiatric medications. E. Caused by psychological factors that usually include anger toward maternal figures. Changes from DSM-IV-TR to DSM-5 sexual disorders. Sexual dysfunctions. DSM-5 has gender-specific sexual dysfunctions aside from male erectile disorder, female and male orgasmic disorder, and premature ejaculation. For females, sexual desire and arousal disorders are combined into female sexual interest or arousal disorder. DSM-5 sexual dysfunctions, except substance, medication, induced sexual dysfunction, now require a duration of approximately 6 months and more exact severity criteria. New in DSM-5 is genitopelvic pain penetration disorder, which combines vaginismus and dyspareunia from DSM-IV. Sexual aversion disorder was deleted due to rare use of diagnosis and lack of supporting research. DSM-5 subtypes for all disorders includes only lifelong versus acquired and generalized versus situational. One subtype was deleted from DSM-IV. In DSM-5, two subtypes were deleted: sexual dysfunction due to general and medical condition and due to psychological versus combined factors. Second, paraphilic disorders. New specifiers in a controlled environment and in remission were added to criteria for all paraphilic disorders. Distinguishes between paraphilic disorders or paraphilias and paraphilic disorders. All criteria subsets were changed to add the word disorder to all the paraphilias. For example, pedophilia is now pedophilic disorder. There is no change in the basic diagnostic structure since DSM-3-R. However, people now must meet both qualitative criterion A and negative consequences criterion B. Criteria to be diagnosed with a paraphilic disorder, otherwise they have a paraphilia and no diagnosis. Gender dysphoria. DSM-IV gender identity disorder became gender dysphoria in DSM-5. Subtypes of gender identity disorder based on sexual orientation were deleted among other wording changes. Criterion A and Criterion B cross-gender identification and aversion toward one's gender were combined. Along with these changes comes the creation of a separate gender dysphoria in children as well as one for adults and adolescents. The grouping has been moved out of the sexual disorders category and into its own. The name change was made in part due to stigmatization of the term disorder and the relatively common use of gender dysphoria. In the GID literature and among specialists in the area, the criterion of a specific diagnosis for children reflects the lesser ability of children to have insight into what they are experiencing and the ability to express it in the event that they have insight.